you can also call it pediatric respiratory because it's very important. These are conditions that are usually very common, and they like to test about it because they look the same upper airway, but there's classic symptoms, buzzwords for each of them. So, common cold. This is the same thing as nasal. I don't know if you've heard about it, nasopharyngitis. Basically, um, it's like common sore throat. And we see it with this infection, rhinovirus, and then flu, influenza, mostly virus infection. It's very common with that. Most of us have had it before, and the symptoms, you get nasal congestion as the key aspect of it. You get congested, and then you are probably post nasal drip. Some runny nose, and of course, cough. Cough. You always have cough. And then sneezing, very common. The irritation of your nose, and then of course you get sore throat. These are very common non-specific symptoms with the virus infecting the upper the respiratory area. Of course, treatment, people have tried so many things. I think you can also have some fever, low-grade fever here. I've had it. People have tried many things, but I think the best thing is hydration and rest. That's all. To rest your body as your body fight the infection. This is the most common in test. The answer choice you should choose is mostly hydration and rest. They can also trick you because this is an infectious process. So precaution, they can add precaution probably in a SATA question. So it's good to just cover everything, like I told you in your test. Don't separate things. This is even though it's an upper respiratory infection, what is the problem? Well, this is a contact problem, contact precaution, okay? This kind of precaution, when they ask you, remember, the precaution is to prevent the nurse from getting the infection and spreading it to other patients, not the patient itself. So the precaution we're taking is you, the nurse, you have to, for contact, you wear some gloves and gown. And then if there's a wound that would splash your face, well, then you have to wear face shield. If this is contact, so usually gloves and gown is the common thing that will be required for this particular disease process. So that's a common cold, nasopharyngitis. Straightforward. Then we increase the intensity. So Croup is a complex name after somebody, but it's the sound that is made with this disease. It's also upper respiratory infection. Okay, mostly it's caused by parainfluenza. So there's a bunch of influenzas. So we have parainfluenza virus. And what this does is it affects the upper airway, and it's a little bit more serious like common cold because of the inflammation it creates. The patient a little bit of hoarseness. They develop hoarseness. And it is this hoarseness that gives them the barking cough. So that's the buzzword, barking cough. When you hear this, think about Croup. That's Croup right there, barking cough. And what does that mean? The barking cough is it's like an obstructive kind of the airway. And so they try that. So it is the sound, is the striding of the airway that causes, they try to cough out whatever secretion they have. Then the sound look like a dog, a barking dog, kind of cough. And that is the Croup. Okay. When you hear stridor, you think about being sharp. It's one of the airway obstructive symptoms. So this can lead to respiratory and distress. Most of the time, they don't go that pathway, but just let you know this is what is going to happen. Of course, since it's an upper respiratory infection, you should expect them to have some runny nose, but the backing cough is classic. They can have low-grade fever also with that. Treatment, as always, supportive. And then we need some oxygen, the same treatment. So this, some people call it bronchiolitis. I mean, basically, it's RSV. That's the easy way to remember it. It's very common in kids, and it's very classic. They have a lot of runny nose. So this case, like nose is running like pipe. Okay, and they may be wheezing. They will wheeze also. They may wheeze, and of course, all of them have cough, and it can lead to respiratory distress. But the common thing is it's a lot of runny nose, runny nose, runny nose. And the virus is that causes the problem is that respiratory syncytial virus, and that causes this problem. Um, it's almost like the common cold, and so it's not that dangerous. But keywords, how to distinguish them: runny nose, some cough and wheezing in a very young kid, and treatment is like supportive. Okay, okay, supportive care. This is also some contact precautions. So remember, these are all contacts. You wash your hands. You wear gloves and gowns when you get closer to these patients. Very straightforward disease. It's very common in kids. Um, be able to distinguish between all of them and a multiple choice answer, and then figure out what is the problem. The most serious one is the one we have on the screen. Very, very serious. I mean, this is life threatening, life threatening. You have to do something about it. You have to be sharp. And all the symptoms is part of the be sharp. Check my prioritization video. It's part of the be sharp method. It's a life threatening problem. They have airway obstruction. So that's what usually kills them. And how does the airway obstruction occur? It's because of due to I think I suspect it's the subglottic inflammation. So below the glottic area, where the glottic area of the airway is below it, so there's inflammation that goes down, that is getting down into the trachea itself, which is dangerous. The they also have the upper respiratory infection. Okay, so it's a form of upper respiratory infection, but that's not the big problem. The main thing about them, okay, the symptoms they will present like restless, they'll have fever, and then tachypnea. Okay, these are their symptoms, but don't worry about this one too much. In your test, there's 4 symptoms that you have to, I call it the 4 Ds. The 4 Ds, okay? The 4 Ds of epiglottitis. And they have drooling. This is a buzzword. One of the 4 Ds. Drooling. When they speak, you can hear them speak, but it sounds like muffled. Yeah, like hot potato. It's so hard. You can hear. You know how you put a hot potato into your mouth. You try to blow it to cool it down. Yes, they have dysphonia. Okay, it's called dysphonia. That's the second D. And then swallowing, they can't swallow. They have pain when they swallow with all the inflammation just below the epiglottis down into the subglottic area. And the last D is distressed airway. And I put distressed airway as stridor. I put it as stridor. They also stride. So they look like croup. They're serious like croup, but they don't have the backing cough. The backing cough of Croup is due to the stridor. So 4 Ds of epiglottitis is drooling, dysphonia, that's the hot potato, painful swallowing, and distressed airway. This is a priority patient. You have to see them. They like this question. You have to know it cold. They like it really, like seriously. They like this because it's an airway problem. If you make a mistake, patient is dead. When they come in, they will be in a position that they can tell you, you can make the diagnosis just by position, physical, without even examining them. The way they look, observation. And the key word is tripod position. So they will be leaning forward. They're leaning forward. Okay. That's what they're trying to do. And they will sit up. Why? If you put them flat, you kill them. Never put it. If they come in leaning forward and sitting up, even when you're telling them to sit up, they don't want to. Yes, this is a epiglottitis just by looking at them. Why? Because their airway is obstructed. So they're trying to open the airway. So they lean forward and open their pharynx. When you move forward, you can see you relaxes your pharyngeal muscle, and they sit up in a high follow position by leaning forward, and that opens their lung, the upper airway, and allow them to take down air. The key thing that they will ask you is this, and please know this. They will trick you. Nothing, I call it nothing in their mouth. Don't put tongue depressor. No. No tongue depressor. You don't need to examine their mouth. This is not just sore throat. This guy, you put anything in their mouth, in their throat, you irritate them, you stress them, the lower airway collapse completely, and you kill them. So nothing in their mouth, no tongue depressor. Do not even examine their mouth. You don't need to do anything. Keep them in the tripod position. Don't lay them flat completely. Just let them be. Whatever position they come in, let them be. And then you treat them. All you need to do is supportive care. Okay, you just give them oxygen. The oxygen usually give in a hood. You can put it in a hood. Okay, they can put their head in the hood or a blow by, and that will provide the oxygen. If you can give the face mask, something is blowing into their nose to give them oxygen, and it has to be humidified air. This is very, very important. Okay, you never put anything in their mouth. And of course, somebody whose airway is going to be compromised, what would you do as the next? If the airway is going to be compromised, what would you do as a next? You need to have emergency intubation set, okay? At the bedside. And then you should have tracheostomy also. Prepare for that. I will tell you what we do clinically. For this patient, if you realize that they're losing their airway, they're about to lose their airway, they have to be intubated in the operating room intubation. Or I would say, let me just change it, control intubation. This is not the one. You may have to take him to the operating room and try to intubate them in the control faction because they may need tracheostomy emergently. So that's why you have to do this all in a setting that is more controlled. This is really good topic. You have to know. You have to know this. Very, very important. Something just came into my mind. There's a few things you need to know. This is given as a vaccination. So, the causative organism is Haemophilus influenza. So it's called, if you have not seen it, Haemophilus influenza. So it's different from para-influenza, okay, which causes croup. It's different from regular influenza that causes cold. This is Haemophilus influenza type B. There's different type B. And if you remember your vaccination, this can be given by vaccination. They get it 2 months, 4 months, 6 months, and then one in the 8th month. They get like 4 doses. And so if they miss any of the vaccination, then we can get any problem. So they can get problems like that. So you encourage the parents to make sure the kid is getting his vaccination. I think I will add precaution. Okay. So what is the precaution? Precaution. Infectious disease. I like to combine stuff. So what is precaution? This is what? Droplet. And you know, droplet, they need what? Just a surgical mask, the next surgical mask on the patient. That's all. Patient doesn't need anything. So surgical mask. It does not need to be in N95. Okay, surgical mask is fine. Okay. And then what usually happens is it has to be in a private room, but the door, this is very careful. You have to be careful. Door does not need to be closed. They will trick you with that. I mean, it's not N95, so door does not need to be closed. So you can keep the door closed, open. So you can keep the door open for that one. You can keep it the door open for that one. Yes, you can keep the door open. You don't need to close it, but the door can be open for that one. Of course, if you have to get in touch with the patient, like body fluid, there's a wound that will splash in your face. If they ask you those questions, the precaution that the disease process involved, you may have to choose some of them, because if you're coming closer to the body fluid, you may add standard precaution depending on what they tell you. But this is very important thing that you have to know about epiglottitis. This, okay, is number one. Who do you see first? If they give you any of them, you have to choose this. You have to choose it first patient. Because it's an airway problem. No matter what, no matter choice indeed. If the patient is bleeding, somebody is bleeding or has neurological problem, I'm seeing epiglottitis, because if you don't have an airway, well, you can leave. You can have an airway and still bleed. It takes a long time for shock to kill you. But if you don't have an airway, time is not on your side. So we have to take care of this particular patient first. This is who you see first. Epiglottitis is going number one. Then we have pertussis. Pertussis is very interesting, and I like it very much. It's a cool disease process. Some people call it whooping cough. Okay, whooping cough. And why? Because this is what happened. The bacteria is caused by a bacteria. So this bacteria is not a virus. It's caused by a bacteria. It irritates the airway. Okay, irritates the airway. They're getting down to the trachea and causes swelling. So there's swelling. Whenever there's swelling, there's edema, right? It causes obstruction of the airway. So you have obstruction. So I like this when then I keep on going. Irritate airway, we develop swelling, we have edema and obstruction. I'm doing signs and symptoms and a pathophysiology, so I can remember it easily as I talk. That's the way so that it makes sense to me. So all these things, what will happen? Well, the obstruction, there is obstructing of the airway. And so they, in order to open the airway, they have like excessive cough. This is like a violent, like the violent cough. You can hear it wherever you are. Really, really, the cough is too strong such that they start swallowing. They inhale, no swallow. They inhale some of the air that is coming from the cough. You see, they inhale the cough, some of them, and this is what the sound you hear as the high pitch sound, and that is what we call the whooping cough. It's a high pitch. As they try to cough out, the air go into the airway, and then they cough, and you hear this high pitch. When they describe high pitch, they may describe this high pitch is the same as the whooping cough. Okay, um, and the cough is so violent that as they cough, the whooping cough, what happens is there's a mucus that comes out from the inflammation. So they're able to clear the mucus out. They clear the mucus out. The other aspect of it is they have what we call post-pertussis emesis. What it means is after they have coughed and they clear the mucus, then they vomit. The vomit is also violent. So if you see it in your SATA question, it's true. Even though they're coughing, whooping cough, they vomit because they post-pertussis emesis. After the mucus comes out, then they vomit. So they repeat it again. You have irritation of the airway swell up, they have edema, they have obstruction. They have to relieve the obstruction. So they cough violently. But in the process, when they cough, they swallow some of the cough into the airway again, and that is the sound you hear, the whooping cough. But the cough is so strong that it pushes the mucus out because they're obstructing. And after the mucus come out, the energy they've used to do that is they end up pushing their gastric content, and they have emesis. So that's why I call it post-pertussis emesis. And this is what is happening. It just described. So in case you see this in the SATA form, they write post-pertussis emesis, mucus, high pitch whooping cough, violent cough, obstructive airway is all part of the pertussis pathway. Okay. So what do you do? The same thing we'll be talking, the same thing we have to talk about. Treatment is supportive. You give them oxygen. And this one, bacteria, there is an antibiotic. You can give them antibiotic for that. The oxygen has to be humidified, okay? Just know that you have to humidify. This one, this is the key. This one, I just remember something. This one is okay to suction them. Why? Because they're vomiting. Post-pertussis emesis. You want to suction them so that they don't aspirate. Epiglottitis, no suction, nothing go into their airway. So if you see a stuck question, don't confuse them. Pertussis is okay to suction their airway because they're going to vomit. And guess what? Because they're vomiting, you have to do that. Lay on their side. They cannot sit up. Unlike epiglottitis, which need to sit up and lean forward, these people need to lay on your side. Otherwise, they will aspirate. So when they're vomiting, because of that, we put them on their side and have suction at bedside so that you can suck their mouth. The side they lay mostly is on the left side because of the esophagus. You don't have to worry too much. But esophagus, start from the right, start from the left of the neck, then you go to the right in the chest. Okay, so in the chest, esophagus, which is where that connects your stomach to your mouth. Start from your neck, on the left side of your neck, then it crosses over to the right side of the chest, and then you go to the left in your stomach. So you lay on your left side so that your esophagus is on top. and then they don't aspirate. So that's why they do that. It's very important to know that on the left side. Okay. One thing, guess what? Parents, they see their kid coughing. What do you think they will go and buy? They will go and buy cough suppressant. I do that all the time when I'm coughing. Well, no, don't do that. Do not do that. Double negative. No. Or I would say no. No to this. No. You shouldn't do that because why? They need to get rid of this mucus. Okay, these mucus need to be getting rid of, and so if you prevent them, you suppress the ability for them to cough the mucus out. That is the main reason why they have whooping cough. If you suppress them from coughing the mucus out, they have airway obstruction. That is different from epiglottitis. They don't have anything. They're not coughing any mucus out. They're trying to open the airway. That's where they're leaning forward. These people don't give them cough suppressant like any other cold medication to prevent them from coughing. You're putting them in a bad situation. Like epiglottitis, this one, there's a vaccination for that. It usually come in DTaP. Um, I'm not going to waste too much time. I don't know if I need to do immunization, but just briefly, this one you should know it. They get it 2 4 months, I think 6 months, then the next one 15 to 18, and then they have to wait for like 4 to 6 years to get it. It's 5 doses. So this is diphtheria and tetanus, and the Pertussis, okay? It's one of the medications, the vaccination, they put it together and they get it. So this is very important. And then pay attention to the things I've said. And they can ask you about a precaution. What do you think is the precaution? It's droplet. It's droplet. And I already told you about droplet. They need a surgical mask. They need a private room, and then the door doesn't need to close. That's all. That's specifically droplet. If you need to include standard precaution when you come in contact with body fluid, then you wear masks and gown. But this is what you need. This is all you need for that particular problem. So let me see. I think and so the last one is infantile botulism. Let me give you some idea, pathophysiology idea quickly. So this is what happened. Okay, we have nerves here like that, and then we have myelin sheet on it, and these neurons, they have vesicles, they have neurotransmitters. So let's say a neurotransmitter for acetylcholine, and then you have your muscle sitting here. You want to fire, okay? It cannot fire. These neurons need to release their content, that acetylcholine, okay, into this is the synaptic cleft or neuromuscular junction, NMJ. And then the muscle have acetylcholine receptors to take the acetylcholine, and then it causes the muscle to contract. Okay, contraction. So this is what happens. This is how you move your body. So the muscle need acetylcholine to contract. Guess what? When you take this toxin, okay, botulism or Botox, that's what we call it. Um, Coming from Clostridium, this is what causes it. Clostridium botulism. Basically, and it releases the toxin. These toxins go here and block this from happening. No release of acetylcholine from the vesicle. The muscle cannot contract. You have what we call absolute paralysis. So you have paralysis basically from all the muscles. Muscles cannot work anymore. There's no acetylcholine. And it starts from your head down. So descending. So you start from your head, come to your face will become flat. You can, have you seen somebody who had a female, they inject the Botox in their face? Nothing, everything is now stiff. So your face becomes stiff, your eyes, your mouth, your neck, respiratory distress, and your body, then you die. So that's what happened. For older people, we get this virus. Let me write this name: Clostridium. Okay, botulism. That's the bacteria that releases its toxin that causes the problem. For this thing, because of that, we should not keep canned food. Canned food, and that we store it for a long time. You can develop that. In the question, when they give you somebody eating canned food, and that has been stored for a long time, you have to be careful. How would you know that this has occurred? You see that the can is swelling more than the original size you bought it, and it's bulging. Okay, bulging can. That's your clue right there. Clue for suspicious. So if you bought something, you go to your cabinet, you see a bunch of canned food that look bulging in nature and swollen. I think you should throw it away. Don't use it. You may have a Clostridium in it that is going to cause problem. So this is what happened for older patients. For kids, common in honey, okay, raw honey basically. If your mother give them and they are less than 1 year old, so this is why they will ask you intervention. A mother told you they're giving their kid honey and they are less than 1 year old. Please intervene. You got to intervene. No, this is absolutely unacceptable. Giving a kid less than 1 year old honey is not good. They are intestines, okay, that is not well developed. So it doesn't have enough bacteria to fight the Clostridium. So not well developed, not matured. So it cannot fight the Clostridium, and therefore they have this toxin released into their system, and that can kill them. Okay, how would you know that a kid infant has botulism? A kid who has developed through the milestone and it can keep his head up, all of a sudden can't keep head up. So the head will be like boggling, leading with his head, or will be on his back like his neck is broken. He can't keep his head up. And then what will happen? You have feeding issue because the muscles that are involved in feeding cannot do it. It's like myasthenia gravis, the same thing. The muscles that help with swallowing doesn't have acetylcholine. You can think about it, it's like myasthenia gravis like, but don't just idea so that you know some of the symptoms they will undergo. They cannot, they have feeding issues, the gag reflex is affected. Okay, gag and reflex is affected. And then they will have constipation because acetylcholine is involved in the movement of your bowel. Okay, there's no acetylcholine, and your bladder to the urinary retention. Anything that acetylcholine is involved with will not happen. But this is the 4 key symptoms I want you to pay attention to, especially can't keep a head up. They may just give you that. A kid fed with honey can't keep his head up. What do you say? He's a priority patient. He has infant botulism. You have to do something about it. You have to be sharp. You have to see this patient because they're going to have an airway. It's like they're losing their face, neck, mouth, then respiratory distress, and then they die from it. And so we have to be careful about that. Okay. Treatment. Luckily, we have immunoglobulin. We have antidote. Okay, to bind the toxin. Okay, and you closely have to monitor this patient, close monitoring to prevent airway obstruction, and of course, supportive care. So all this is very important for this patient, just to prevent the airway from getting obstructed. And then the best way is to recognize it, be able to see what it is, and treat the patient as much as possible. This is all I think we will cover today. Thank you for listening. There's a couple of upper respiratory infection in kids, be able to distinguish between them and see and who is a priority, and manage it appropriately. Thank you for listening, and keep charging. Please subscribe to the YouTube channel if you like this video, and join our Facebook group. Thank you very much.